what did you think? Yeah.
I am really impressed that in the last year and a half, she's done a lot of thinking.
Yeah.
And a lot of sort of testing out the waters for herself to sort of see what's, where those minefields might be. Minefields that a year and a half ago, I'm not sure how certain she was were either minefields or something she really wanted to work on. So it felt really different today, where she's had maybe, like some unfortunate dynamics in relationships with boyfriends, with friends, with alcohol. And sometimes those life lessons lead us to seeing things in ourselves that may require some more attention. And I had no idea, obviously, because I haven't seen her or spoken to her. So it was really nice to see that she's come so far and that she's even engaged in therapy, because I think at the point we spoke last time, she was like, yeah, she was sort of thinking about it, but not quite there. At this point now, having some sense of Charlotte and her investment in treatment, one of the things that became more relevant today is, well, if you're really interested in working on these things, what would actually be a good match? What kind of treatment would be a good match? Because not every treatment is suitable for each person, and not everyone needs a specialized treatment.
How would you determine who does and who doesn't need a specialized treatment? Like, how do you make that determination?
It's a great question. John Gunderson, as I mentioned, my mentor, who I think has really rocked the field in some really productive ways by putting borderline on the map, but also creating GPM, good psychiatric management. And his whole philosophy behind GPM is to train as many psychiatrists, mental health professionals, in good psychiatric management for borderline as a way of like a first line of defense. And I really only think these expert sort of treatments end up being prioritized when some GPM or other really good therapists, that therapy doesn't take flight. So you see a very good therapist, but for whatever reason, maybe it's a lack of real training in personality disorders, somebody languishes in the treatment, that's when to introduce more specialized approaches. That's when people go to either a specialist or a residential program, depending on their need or the sort of severity of the problem.
With Charlotte's question about, can people get better and sort of what does that trajectory look like? What would what would be the trajectory that you would take with someone, if you can say that, or how you would think about it and organize yourself?
First you need to get really clear on a diagnosis. I'm not a big fan of diagnoses, I'll be honest, but at some level you need to understand the variables at play so you have some clear sense of where you're going in the therapy. Then you develop sort of a frame. That's a very TFP approach, but I think for any treatment to have sort of a frame, which is a set of expectations about what you're both agreeing to as you embark on this endeavor together. And that can take about, a good month. Just alone to really get a very clear sense of the vulnerabilities that the person's coming in with, what their treatment goals are, problems, treatment goals, and the frame of treatment. And then you're sort of off to the races. When you're dealing with some layers of complicated problems, you're really investing in several years of therapy. But the interesting thing about folks who just have BPD is that as one gets older, one improves without intervention most of the time. So people often say, well, what's the point? Then why get therapy? If I know when I'm in my middle ages and when I'm in my 50s, I'm kind of mellowed out, why get treatment? Well, when you're between the time you're sort of like 18 and 30, you start finding partners, building solid friendships, having children, and you miss the boat on doing that if some of these vulnerabilities are really active because they destroy oneself or relationships. So I would say 2 solid years. And then maybe sometimes longer. Sorry.
No, let me ask you this. We have people on our channel who are older, right? Who didn't get diagnosed. Partly, I think it's a product of our generational You know, it just wasn't around. I
Right.
mean, I think a lot of younger people now know about it, and the stigma doesn't seem as bad or something. So like, people are like, I have it, and which is great. But what do you say to people who are in their 50s or 60s who are still really struggling, or who just really found out they have it? Like, what do you say to them? I mean, should they just give up? Or, you know, I'm in this middle range of, I lost almost 20 years. I lost my 20s and my 30s. And while things are better, I paid. You know, I endlessly have paid for that loss. I've tried to fix it, but some of it is not, I can't buy back 20 years. Yeah. But at least I got it at 40 or 39. If I had gotten it now, almost at 50, that's a heavier load in a way. And yet, why suffer for the next 20 plus years of your life if you don't have to? So what do you say to people in their 50s or 60s?
Okay, so I'm a little bit of an eternal optimist in this way. But I've had many patients come to me later on in life and make very good use of therapy and change their trajectory. So it is not something, if you're 50, if you're 60, if you're 70, don't shy away from treatment because it can be incredibly beneficial. The thing the reality, long-standing patterns fundamentally are harder to change. So the longer you've had a way of navigating yourself in the world, the more it's sort of reinforced from a behavioral perspective. It can be more challenging to change, and it also can be changeable. It can be addressed. So if people are watching this and thinking, should I pursue treatment? And they're interested, absolutely. Absolutely.
I mean, and are there some benefits to being older? I mean, is there ever a benefit? I mean, are people more committed? Are they more, or you haven't necessarily seen that?
I think there's a level of commitment because hospitalizations, suicide attempts, or self-harm, big sort of high-risk scenarios have really sort of destroyed them and relationships over long periods of time. So it becomes a situation in which people unequivocally can see that they're contributing to the problem, the challenges that they're experiencing in life, and are often more open to looking at themselves. When you're younger and something happens, sometimes it's easy to say, oh, it was that boyfriend or that friend or that parent or that teacher. Then it happens again, feeling maybe like a big one is people do something to you, like you're feeling very much done to in the world. And you can sort of chalk it up to that a second time. But when it happens a third time, a fourth time, and you start seeing yourself as the common denominator, that pattern becomes undeniable. And it then allows for like a window of looking at oneself a little bit differently than if you were just starting to experience these challenges in life.
And just to like take it back to Charlotte, you know, Charlotte's not 20 anymore, and she's not 30 anymore. And it was evident to me in the session that she is able to look at it in that way now. You know, she sees herself as a common denominator.
Right.
You know?
And I think that's actually a big difference from our first interview, that there's a willingness and an openness, and she still has the rest of her life to experience differently, and the awareness and investment differently than she did a year and a half ago, which is not something to sort of take lightly. That's a big deal in starting to embark on something like this.